All right, everyone, welcome to our second session of our second five-part series of building a resilient food culture. Today, we will be talking about the growing health intervention and movement, Food is Medicine. My name is Adam Morgan. I am the Advocacy Coordinator for Greater Pittsburgh Community Food Bank. We have a great panel lined up for today, so I will start with a few housekeeping items and then we'll get started. The webinar today is being recorded and will be sent out to all registrants in the coming days. If you'd like to watch any of the previous sessions, you can find them on Food 21's website under resources. The link we will share on the closing screen today. Feel free to submit questions or comments throughout the session as the panelists are speaking. And we will reserve the last 10 minutes or so to address those questions. So allow me to introduce our panel today. First, we have Representative Dan Frankel, representing District 23 in the House of Representatives in Pennsylvania's General Assembly. His district is comprised of several Pittsburgh neighborhoods, including Squirrel Hill, Greenfield, Point Breeze, parts of Shadyside and Oakland. He is the Democratic chair of the House Health Committee. Representative Frankel has also served as president of the Jewish Family and Children's Services Board and is on the boards of Maggie Women's Research Institute and the Jewish Healthcare Foundation. Next, we have Dr. Stephen Thomas, professor of health policy and management at the University of Maryland and the director of their Center for Health Equity. He is one of the nation's leading scholars in the effort to eliminate racial and ethnic health disparities. Finally, we have Simone Firk, Executive Director of Food and Nutrition Services at the University of Pittsburgh Medical Center, overseeing the day-to-day food and nutrition operations for the Health Services Division with more than 3,000 employees. She leads system initiatives in food and nutrition for all UPMC hospitals, to include the implementation of an integrated IT platform, as well as standardized menus, strategic sourcing, and services through a service line leadership model. Thank you all so much for being here today. And we'll start with Chairman Frankel.
Thanks, Adam. And I assume everyone can hear me. And I'm honored to be on a panel with Dr. Thomas and Simone Firk. I hope I'm able to listen to some of that, but as I mentioned earlier, I may not be able to stay for the entire program today because we are in session and I have a caucus to go to shortly. But as Democratic chairman of the House Health Committee, I joined with the Pennsylvania's Legislative Black Caucus for a policy hearing a year ago on health disparities in this Commonwealth. We were in the early months of a developing pandemic. There was a lot we didn't know about COVID-19, but we knew exactly who was going to be harmed the most: communities of color and poor folks. How did we know that before the data came in? Before we even fully understood the behavior of this dangerous virus? We knew it because racial and economic disparities in health outcomes are brutally universal in our society. They are persistent and pervasive, and no one policy can fix the problem. Today, we are here to talk about food policy, one of the important drivers of these disparities and one that we know a lot about. In Pennsylvania, 1.4 million people are facing hunger. 384,000 of them are children, according to an annual report by Feeding America. That's a lot of people, but the number is not spread evenly throughout the Commonwealth. In 2018, the most recent year for which we have numbers, 1 in 10 white Pennsylvanians said they experienced food insecurity. For Black Pennsylvanians, it was 1 in 4. For Hispanic Pennsylvanians, it's even higher at nearly 30%. Alongside food insecurity is the problem of obesity. 1/3 of our Pennsylvania adults are obese, and obesity rates track very closely to poverty rates. If you're overweight, you are more likely to be subject to impaired immune function, hypertension, type 2 diabetes, heart disease, stroke, depression, and anxiety. And of course, being sick in this country is expensive. When people cannot feed their families, they can't begin to think about training for a better job or saving money to cover for an emergency, like a flat tire or an illness that keeps them from working. Struggling to cover basic needs means at best treading water. At worst, it's losing ground, losing your home, losing your job. In summary, being poor enough that you worry that you will run out of food before more money comes in is again bad for your health. It's bad for any hope of class mobility. I talk a lot about healthcare costs and the money that we put into a system to pay hospitals lots of money to care for people when they are really, really sick. And one of the most frustrating things about it is that we know we can help people avoid illness by simply investing in what they need on the front end, including access to nutritious food. The good news is the government can and must help. One of the ways we know that policy can make a big difference is addressing food insecurity and nutrition that it already has. 2 federal programs designed to address food insecurity are WIC, Women, Infants, and Children, which provides supplemental food to pregnant and postpartum women, infants, and children under 5, and SNAP, which provides voucher payments to purchase food for most people whose income and assets are low enough to qualify. Research finds that both programs improve birth weight. That, in turn, leads to improved cognitive outcomes for children. In fact, higher birth weight is associated with a wide range of positive adult outcomes, such as higher wages and fewer adult onset conditions. So investing in more food and nutritious food for children has lifelong benefits for kids as they grow up, and then for their communities to which they can then contribute. 12 years ago, President Obama signed the Healthy Hunger Free Kids Act, which strengthened nutrition standards for meals and beverages provided through schools. Among children living in poverty, these quality meals and other programs reduced obesity by nearly half by 2018. Those are some government programs that have made a difference and continue to make a difference in reducing food insecurity, improving nutrition, and consequently reducing racial health disparities. You'll notice that those are federal programs. Pennsylvania is not doing a good job at addressing these issues. There are a lot of great legislative answers to the problem of food insecurity in the General Assembly. Unfortunately, they all have one thing in common, which is the majority party hasn't scheduled a single one to receive consideration. But I think it's worth talking about some of them just to show that ending hunger in the Commonwealth is going to take money, yes, but also creativity and even a little redundancy. In my opinion, the single biggest thing the state of Pennsylvania can do to address these issues is to raise the minimum wage. 40 hours of work a week should pay enough to feed your family, pay for your home, and allow you to plan for the future. Anything less is immoral, and it ensures that a certain segment of the population will just never be allowed to catch up. Last year, the Wolf administration put together a policy recommendation report for reducing health disparities in the wake of COVID-19. It provides a map for expanding access to our wonderful food banks and other supportive services with or without a pandemic. The report called for eliminating citizenship, residency, or document requirements from all Commonwealth and city food security programs. SNAP benefits are and always have been withheld from undocumented immigrants by federal law. That's obviously a cruel and nonsensical policy, and it means that we need to work that much harder to make sure we are reaching out to immigrant communities with state and local programs. It also called for increasing the threshold for the Farmers Market Nutrition Program, both for WIC recipients and seniors. It talked about making it easier to use food assistance benefits to order groceries online. This is important when you're trying to avoid a contagious virus, but it's also key when you don't have reliable transportation or you're at work when a local grocery store is open. I'll mention just a few more bills that would make an immediate difference for addressing food insecurity in the Commonwealth. Pennsylvania requires recipients of the WIC program to reload their plastic EBT cards in person with their children in tow. The technology exists to reload the cards remotely, but Pennsylvania hasn't invested in it. That should be a high priority for the Commonwealth. We should be removing obstacles to accessing these programs. We need to encourage the development of more food buying options in high poverty areas. Research says that people living near full service grocery stores tend to have healthier diets, including higher intakes of fruits and vegetables and lower levels of obesity. Residents in low income and rural neighborhoods where grocery stores are scarce are often forced to rely more on corner grocery stores with little stock and no produce. We should reestablish the Pennsylvania Fresh Food Financing Initiative. Until 2010, the initiative provided grants and low-interest loans for the construction, rehabilitation, or expansion of grocery stores, farmers markets, and other healthy food sources to low, moderate income areas in need and other underserved communities. We need to address food insecurity on college campuses, where a significant number of students report struggling to get their basic needs met. This long ignored issue needs more study so that we can best target to help students. But in the meantime, we need to issue grants to schools to seek to open food pantries or otherwise address food insecurity on campus. A bill in the Health Committee right now, the Pennsylvania Preferred Food Bucks program, would allow shoppers to stretch their SNAP funds further when they purchase fresh produce. Some counties are already providing this option through grant funding, and we should be able to offer it to Pennsylvanians statewide. Finally, the importance of school meals cannot be underestimated. For many children, the calories they get through school breakfast, lunch, and after-school snacks are the majority of calories they get in a day. In fact, schools throughout our state have started very successful backpack programs to help those families who rely on school meals to help supplement their family diets and need extra help on the weekend. We should be doing more at the state level and within school districts to make sure families take advantage of these programs. Our state and federal policies have long treated the need for food assistance as a moral failing among recipients, delivering help along with suspicion and judgment, making it hard to access and leaving some without the help they need at all. Instead of debating and studying the ways we can lift up communities most in need, we are consistently put in a position of fighting back efforts to cut funding and add obstacles. With the policies I've talked about today, we can acknowledge that widespread food insecurity represents the moral failing of our society and that our systems are disproportionately harming minority communities. And when people fall on hard times, instead of providing a true safety net to help them back onto their feet, our programs become complicated, time-consuming puzzles that they must solve to survive. This week, we here in the Commonwealth and the General Assembly are in the midst of a high-stakes budget negotiation. We have an unprecedented infusion of federal funds intended to help fulfill government's most basic and essential role of protecting and supporting our most vulnerable through their toughest stretch. We have the power to both ensure that all Pennsylvanians have their basic needs met and to address the ever-widening health disparities that stop this Commonwealth from fulfilling its potential. Food policy is a great place to start in that quest, and I'm grateful to be able to participate today in this discussion about that. So with that, let me conclude and turn it over to the rest of our panel. And again, appreciate the opportunity to be here. And I will try and, I do want to listen to as much as I can of our other panelists. So thank you very much, Adam.
Yeah, thank you very much for being here. And thank you for talking about our children so much. I think this health intervention of using food as a medicine and to combat chronic diseases is still relatively new. I think the relation between nutrition and children health and their development is longstanding, and that's something that's so important because when we're talking about childhood development, particularly before the age of 5, there's no getting that back if they miss it, and nutrition plays such an important role in that. And thank you for mentioning those programs that help address that. All right, now we will turn it over to Dr. Thomas from University of Maryland.
I think I'm unmuted now.
There you go. All right.
Okay. Congressman, you are a source of inspiration to me today. You hit all the right notes. It's so exciting when our members of Congress and us in public health are singing from the same hymnal, so to speak. And, if you go back far enough in time, back in the 1960s, I think it was Dr. Jack Geiger down in Mississippi working with John Hatch, and he was seeing the consequences of poor nutrition. and yet the people down there lived in a place where you could put anything in the ground and it would grow, and yet they were suffering from malnutrition. And so he began writing a prescription, and his first prescription, Congressman, was for a tractor. And the federal government balked, and he said, the people need food. And lo and behold, he got that approved, he got that tractor. And Jack Geiger is the father of the community health centers that we now know today. And we should never take for granted. That was a fight to ensure people had access to care. So there are a lot of things that in our lifetime, we can look back and say they began very humbly, and now they are part of our safety net. And the COVID pandemic has exposed the phrase in our safety net. And yet it has also shined a light on innovation. So in the short time I have, I want to talk to you about some innovations that actually come out of Pittsburgh and that are now being scaled across the country. I'm going to take a chance here and share my screen. I hope you can stay with us, Congressman. From 2000 to 2010, I was on the faculty at the University of Maryland in the School of Public Health, where many of the innovations I'm going to share with you now had their origins. And so since we're talking food, I will start with food and let you know what happens when you bring our student population into the community, and we have an opportunity to show them, I say, Congressman, to get mud on their boots. So they're actually out in the neighborhood where the people live, work, and play. And so I want you to imagine a business like a steakhouse. You know, when one of the Pittsburgh Steelers retires and opens up a steakhouse, but 10, 15 years down the road, that steakhouse changes hands. And now it's a nightclub. And before you know it, it's an open air drug market. And before you know it, it's an eyesore. That's what happened. The eyesore building was donated to the Catholic Church. And the Archdiocese came to us and said, we would like to make this something of value in the community. Can you help us? And we stepped up and we helped them reimagine what this could be. This is a gutted building with a trash-strewn overflow parking lot in Temple Hills, Maryland, about 8 miles from the White House. You can see the maps there. It was a restaurant for over 20 years. And so sometimes you have to see in the debris something good. You know how sometimes you see the construction sites, they say, excuse our dust, we're making things better. Well, that's what this was. And early on, our students began to do, using human-centered design, interview the residents in the community. What would you like to see in this facility? How can it improve your health? And they came up with a range of ideas. We brought together partners, the Catholic Charities that owns the building and the land. We brought together our community hospital. And a long story short, this facility is now fully built out with comprehensive dental services, primary care services, legal services, Congressman, to help people with immigration issues, and the law offices out of Washington, D.C. providing pro bono care. And one of my students' ideas was, you see their little box there, I won't show this video, was that the overflow parking lot should be a community garden. And I have to raise the money for all these ideas. But to make a long story short, that little community garden is, again, that's the overflow parking lot. And that's the old kitchen. It's amazing what you can build from the ground up. And I said to them, if you had a chance to build from the ground up, would you build your great-grandfather's clinic? No, you'd build something for the future. And so now we have a farmer's market that shows up there. And I'm just going to give you a little snippet of our 2020 annual report. We are actually producing food. This is our little timeline from 2014 to November. You can see the actual pounds of produce that we have produced. We have a market value on that. Everything we raise, we send to the kitchens of the Catholic Charities, and they literally use it to feed the hungry. Here's our little community garden sign. Here's an idea of the university being a better community partner with our neighbors. Sometimes our academic institutions cast shadows on the very neighborhoods who need our services the most. And I know that East Liberty community and the Hill District, and I know that there has been progress made there over the years. And so here again, you can't do any of this alone. If you want to go fast, go alone. If you want to go far, go together. The hospital maintenance crew built the raised beds. We now have 12 raised beds. And then as we started building those raised beds, Congress, the people in the neighborhood said, hey, can I help? It's like Tom Sawyer. We gave them a brush and they all started painting. And now there's a sense of ownership. Now they see where their food comes from. We deliver food baskets to the local businesses, and we're trying to, again, bring back a sense of community. The rest of this particular piece goes into the actual tonnage. We have produced, in this growing season, we will hit 1 ton of produce, Congressman. That makes us a farm. So we went from the notion of community garden to an actual farm. And that allows us to train people as master gardeners. It allows 4-H to get their credits in the community. It allows the Boy Scouts and Girl Scouts to use our farm as a project. And so we're working with our Department of Agriculture. We are a land grant institution. And what you're seeing here is my doctoral student who's now completed her work. And this was her dissertation. Amazing. And so it's with that recognition that sometimes it's the little things, and you have to start sometimes small. And there are times, Congressman, when you can see in that debris something beautiful come from it, and others only see debris. And I think it's important that we start to reimagine what's possible. This is a literal opportunity to teach kids about science, to teach kids about agriculture, to teach kids about entomology, the study of bugs. Who could imagine what might inspire them? And so I'm going to take a chance and come out of this and share with you one other example from my experience in Pittsburgh. My work there is where the hair project, the barbershop health project, was actually born. And that project now has been endorsed by the White House in the era of COVID to address issues of outreach and education. And so I'm going to take a chance here. Here we go one more time. And I'm going to take you into my world of the, here we go. I've gotten all my buttons clicked at them, and we're going to see how this works. I'm going to take our friends into the beauty salon, and I want you to see how we have literally transformed a beauty salon into a COVID vaccination clinic. Adam, can you see that as full screen?
Yes, I can.
Okay, here we go. Welcome to Shots at the Shop, and today we're at Katrina's Trey Shades Hair Studio in Capitol Heights, Maryland, which has been amazing.
My favorite part is saving lives, seeing people get vaccinated, because a lot of people are hesitant to get vaccinated. So if I can advocate and encourage them, I'm excited to do so.
A lot of people just don't trust the system. So we have to take the time to answer their questions. And what better place to do that than in a place they already trust?
They can dispel some myths and misinformation that's out there, and then they can refer them to others with, more specific questions.
I've honestly seen about 25 to 30 of my clients go from, no, I'm not getting that vaccine, to sure, I'll get vaccinated or show up at your clinic on Monday.
I got my vaccination.
Well, I was comfortable with coming here. I actually feel comfortable here than I would at a normal clinic.
I like it because I know this place is not like it's not strange or anything.
You truly are, barbers and stylists, a trusted voice in the community. And we want to tap into your expertise and be a good community partner.
It's just for us to be knowledgeable in these health disparities so that we can have conversations behind our chair, because I believe that we're more than just a hairstylist. We're touching people just like doctors and nurses do.
Any barbershop that wants to hold a vaccine clinic in their place of business will find you a clinical partner.
So we can bring in all the clinical expertise.
I say just do it. Just work on saving lives, keep advocating for the community, bringing more people in. And I do believe that having a vaccine clinic at a salon is well worth it.
It worked here at Trey Shades, and it could work in your barbershop or beauty salon as well.
Yes, son, you're fully vaccinated. It was a great day.
All right, all right, all right. You just never know what will take off and have a life of its own. And that introduced our legislators and other medical partners to the realization that in the Black community, barbershops and beauty salons are sacred spaces. I have to say, Congressman, no self-respecting Black barber would ever say, I get you in and out in 15 minutes, all right? You're going to be there for a while. It's a whole community gathering. And while COVID has opened the door for us to be there, our hospital partners have committed to stay. So now we bring in the diabetes screening. Now we bring in the nutrition education. Now we literally bring additional health promotion and disease prevention resources into these spaces. And last but not least, Congressman, my first three barbers and stylists have now been certified by the state of Maryland as community health workers. I'll leave you with this. It's because of legislation that you have sponsored in the past that allows community health workers to be covered by insurance. But Congressman, I talked to an insurance executive and I was so excited to say, our barbers and stylists are certified. And there is a CMS code to get them paid. And that executive looked at me with a wry smile and said, just because you place a claim doesn't mean we have to pay. And my mind flashed to that nurse on the phone arguing for a transplant or for a medication, or I had no idea that it could come down to that. So I think the oversight and implementation of the spirit of that legislation is important that we keep front and center, because these trusted health professionals, these barbers and stylists, once they become community health workers certified, they're frontline health workers. And what they do should be legitimate for reimbursement of their time and effort. And that's how we can move the needle forward. Let me wrap up by just, I have to go in one more time because, I gave the shout out there to the ladies in the salon. But you do also need to know that, yes, guys, you know who controls health in our homes, right? Let's be honest. Let's be honest. Who's the one trying to tell you to get that colonoscopy? Everybody out there knows that sometimes it's the ladies in the house that keep us alive. Adam, are you able to see this?
Yes, I am.
Okay, so this is a Washington Post story, front page, a new national model barbershop offers coronavirus shots in addition to cuts and shaves. I'm saying this because the whole hair campaign, which is now national model, had its birthplace in Pittsburgh. What you're looking at here, Congressman, is that we not only need to take the information and demystify it and sometimes translate it into different languages, but we also need to transform it into different formats. So you're looking here at an artist's work that's working with us to create a graphic novel. And I think that's an important part of repackaging and meeting people at the level of their understanding. Adam, did that switch? Do you see the President Biden fact sheet?
Yep.
Okay, and here's the president's announcement. I'll just go down very quickly because for me, again, something so humble as a barbershop is now part of the national campaign. And as you can see here, there in that announcement, Shots at the Shop, new initiative to engage Black-owned barbershops and beauty salons in the COVID fight to ensure that we get 70% of our population immunized by July 4th. I want every shop, not only in the city of Pittsburgh, but also in the state of Pennsylvania, to be part of this campaign. We're having a training tonight, and Adam, I'll make sure you get information to get people signed up. Shea Moisture will put $1 million on the table, Congressman, $1 million for 1,000 barbershops. They'll each receive $1,000 for their time and effort to transform their salons and barbershops into health information portals. And with that, Adam, I'll turn the floor back over to you. Thank you so much.
Thank you. And I absolutely love that model of using hair salons and barbershops, particularly when you're talking about nutrition and eating healthier, because really when it comes down to it, that is a behavior change, right? And the best way to change behavior is to go and meet people where they already are. So if we can utilize this kind of model, whether it's for the health and nutrition, whether it's barbershops and salons, or local diners, or restaurants that these interventionists, these outreach specialists can go in and try to teach how to prepare, or even just trying these new and different healthy foods. I think that'd be a great model that's open for replication.
Absolutely. That's where social norms are set. So you can
Absolutely.
give people food, but now we have to teach them how to cook that food.
Right.
We're going to work on the barbershop cookbook. Take that good food and make it more healthy.
Very good. Well, thank you so much, Dr. Thomas. And with that, we will turn it over to Simone Firk. Simone?
So good afternoon. I'm very humbled to be part of this esteemed panel. And to Dr. Thomas's point, now we need to teach people how to cook this nutritious and healthy food. So I will be sharing my screen, if I can. Adam, it doesn't let me do that. Are you able to share my PowerPoint? Or are you able? There we go.
There you go.
Okay. Can you go to the next slide, or can I drive that?
There you go.
So what I would like to talk about a little bit is the practicalities of food programs that we are attempting to either implement or have implemented within the hospital division of UPMC. As the Executive Director of Food and Nutrition Services, I oversee what we call a service line. So all hospitals within UPMC report up through me, and we have various outlets where we create either menus, education programs, clinical nutrition strategies, and we collaborate with our corporate entities like our health plan. We collaborate with physicians individually or physician clinics. And of course, we create our own programs based on the voice of the customer that we receive. With that being said, I wanted to talk a little bit about family support, access, trust, which Dr. Thomas spoke to a lot, which I really appreciate, tools, and some education. Can you go to the next slide, please? So in my experience here at UPMC and with our programs, and having spoken to several of our physicians about how can we make a program successful, or how is the patient going to be successful, the biggest obstacle at times seems to be the family support. So when we are taking the head right now of this is a patient that needs a medical intervention, and let's say it's a cardiology patient, and it's the first timer potentially, which is likely the most success for us to change habits. What we find in over 90% of the times, the patient's feedback, why they fall off the wagon, why they will not continue following the prescribed diet, is because the family is not supportive and doesn't participate. So the other thing is, when we ask the question, is your family supportive? The family might voice, yes, we are, but what does family support look like? So what we find is that if the family is willing to join whatever that lifestyle change is, if they're willing to consume the same meals, even if there's an add-on to their meal. But if they're willing to cook the same way, they're willing to, while at home and sharing meals with the patient, are willing to try new recipes, the patient is most likely successful. Do you want to go to the next slide? And then when we talk about access, and particularly this last year, I think has really brought to the forefront, or the last 16 months, what challenges might be out in our communities. But what we have found is in one of our hospitals, we have a food pharmacy. And traditionally, the participants in the food pharmacy would come to the hospital. They came once a week, they got an educational session of sorts, and then would pick up their box of food to take home. However, during the pandemic, we were not allowed and not able to invite the public into the hospital, so we had to come up with a different model. And truly had to figure out, how do we get food to our patients? And it really turned into what mode of transportation does someone have? Are they using public transportation? Do they have access to a car? Are they coming by bicycle? Are they walking, or are people homebound? And so, which then turned into, with all these different options, how do we package foods? Because I can pack a box and I'm making it up, let's say 20 pounds of food. Who can carry that to the bus station on a bus, or put it on the bicycle and get this home? And from a homebound patient perspective, if the family members that are supporting this patient can't get to that pickup location, how do we get product to them? So in the end, what we found, and what was the easiest for our patient population, was we created a delivery model. So 2 days a week in this particular hospital, for half a day, we have an employee in a van delivering food boxes to these patients that are in our food pharmacy program. And in this particular program, it is a diabetes clinic. And the goal is to reverse type 2 diabetes through lifestyle changes. Having said that, the other thing that is really important to consider is, at what time of the day can somebody pick up? At what time of the day can somebody receive goods? Oftentimes it's in the middle of the day, our normal business hours, that products and services are offered. But we really need to consider people that are working, and especially our frontline workers as well, that might be working in those hours and can't get to these offerings. So we really need to rethink at times, how do we make ourselves available, and what are the after hours availability options within our communities. And then lastly, what we also found is, who is going to be receiving the food? Is there some responsible adult at home who knows certain products need to be refrigerated? Or is it delegated to a child who might take the box and put it on the floor and wait till mom and dad come home? So I realize this sounds very oversimplified, but by the end of the day, this is coming down to basics. Can you switch to the next slide? And with that being said, I want to talk a little bit about what we found from a trust and also from a tools perspective. Again, to Dr. Thomas's point, within a community, you want to work with a community partner so that the families or the community feel they can trust that outside source, in our case being a hospital. And then the other thing that we found, we had created a food program for lifestyle reversal of diseases, and offered, for example, cooking classes. And what was really surprising, and it didn't matter what income bracket the attendees were from, that we had quite a few people who said, I have never held a knife, or I don't have certain tools. So we needed to first validate what type of tools do you actually have at home? Do you have a stove with an oven? Do you have a hot plate? Do you have a microwave? Do you have none of the above? There are literally individuals who might sublet space. They might not have traditional kitchen space available. And then, of course, the other things are kitchen basics available. Your pans, your knives, your cutting boards. Are measuring tools available, or do we need to provide any of these products? And we found that, and we will pilot it with another program, we will likely have some sort of cabinet, so not every attendee will get the same product because not everybody will need this. But if somebody needs, I'm making this up right now, let's say a cutting knife and a board and maybe some measuring cups, we can provide that, ideally within the program that we will be offering. And then, Adam, can you go to the next slide, please? And lastly, from an educational perspective, a lot of lessons learned on our part. And the good news is those are lessons that will make us better as a provider, that will make us better within our communities if we come up with programs around this. For example, when is the best time to hold educational sessions? Is it during the week? Is it on weekends? Is it during the daytime hours? Is it during the evening hours? And then secondly, it's the basics of truly teaching how to hold a knife, how to cut, how to slice or to dice, or explain the difference between what's dicing, for example, when a recipe calls for dicing an onion, for example. And the other thing is how to read a recipe, how to follow a recipe. We also find that at times we have community members and even employees who might not be able to read. So we have to create some sort of a picture menu instruction without embarrassing the individuals, because again, that's a reality, and so we need to address that reality. And the last piece is what we also try to do is, because when you're new to something, it can get frustrating and complicated, how to set up your cooking space, how to set up your ingredients so that when you then go back to that recipe and you're going back to your process and you're nervous about it, which a lot of our patients and participants have actually said that they are sending their family away when they have to learn to cook. Or they ask the wife to leave the kitchen because they're nervous holding the knife and they don't want her nagging at their back. And so it's really these types of basics to keep in mind when a program might have funding and a program in its conceptual space has been conceptualized. And so my team truly is basically the boots on the ground that oftentimes helps to convert this concept into an actionable program. So that would be it for me right now, Adam.
Thank you so much. I love these different points you're making, because just yesterday, USDA released a survey and study they did of SNAP participants, and the survey was about asking what their barriers were to eating healthier food. And each one of your slides kind of touched on a different one of the barriers that were mentioned. And I particularly liked your intervention of pre-cutting and pre-preparing some of the foods that you give out, because that was the #1 response in the survey. It was 30% of respondents didn't have the time to prepare meals from scratch. So being able to not only provide new, different and healthier foods to your participants, but you're even helping them, get it prepared so they don't have that doesn't have to be a barrier. If some of the work is already done for them, it's just that much easier for them to prepare that healthy food for their families.
Oh, absolutely. And it is intimidating. For example, one of our first programs, so that's why it will always probably be in my forefront of mind, is we provided butternut squash, but whole butternut squash. And although I consider myself a foodie and I'm very apt in the kitchen, I have a hard time cutting a butternut squash, but at the time it didn't even cross our mind, to be really honest. So we were very ignorant to the fact how hard it is to cut a butternut squash, but we taught it. We showed them how to peel a butternut squash, how to cut it. And we got the feedback that people didn't do it at home because it's hard, it's difficult. And over the time of the food pharmacy program, what we found, because again, to your point, a lot of participants had a hard time prepping the product, the produce. And so now we oftentimes pre-prep and pre-slice and pre-dice product, repackage it so that at home, our patients can be successful.
Great. Good, Dr. Thomas, you can come back. I saw you on and off with the video. Unfortunately, Chairman Frankel had to jump off the call. He's in Harrisburg and he had a caucus. So if anybody has any questions that you'd like answered by him, please feel free to submit them and we'll make sure we follow up with him to get those answered. Dr. Thomas, first question I wanted to send it your way. We've talked about engaging the community outside, the quote unquote walls of the healthcare system. And it seems like you've been doing that with your hair project. So how can we incentivize or further encourage more healthcare providers to make that leap and to do it in a non-traditional manner?
Well, we've done that sometimes, with a grant. Simone probably knows about, we got a grant to do, and then the grant comes to an end. And then nobody steps up to make it part of the actual infrastructure. And so I just have to hold those results up to our leaders and say, we've been here before. We demonstrated that this can work. It was a grant project. Grant came to an end, but we need long-term investment. And I'm hoping that the pandemic has done that. What you just described, Simone, is so important. The lessons that we learn along the way, we take so many things for granted. I saw the same thing. Legislator passes laws so that you can use your WIC voucher. Guess what? At a farmer's market. And the people get to the farmer's market and have no idea what to do with an eggplant. And it takes time. And so the notion that in the medical system, we write a prescription and we literally tell you this antibiotic you take 3 times a day on an empty stomach or whatever it might be. But in the food case, we just give them the food and assume they know how to use it. And I think therein lies where we have to really break it down. So think about cooking classes that go along with it. Think about street fairs where you're doing tasting demonstrations. When people go into Costco and a lot of the grocery stores now, there's little tasting stations. I think they're used to that so they can try what a butternut squash actually tastes like. And then how do I take grandmother's recipe that was so good but has so much butter, get that same flavor, but reduce the exposure to fat without losing the texture? Guess what? Our food scientists know how to do that. We can help people change their product mix. So I think it's showing by doing and then getting a commitment for long-term engagement. And I'm hoping that COVID has done that. I think that the food pharmacy idea is just amazing. For many African Americans, for example, getting vitamin D is a challenge. They're vitamin D deficient. And knowing how to prepare foods that would help them get their vitamin D would be extremely helpful. I think actually putting your hands in the dirt helps. Actually, seeing where food comes from and doing that with kids. So out at our Mona farm, people are out there volunteering with their small children. And therefore, the kids know early on where spinach and radishes and all these, and they have a lot of fun. So I think we have to change the food culture and counteract. Be mindful now. There are people with a lot more money than we have and a lot more talent in terms of changing behavior, advertising every single day to the very populations we're trying to reach. And so we have to be very creative, like having support groups around food, Simone. And one of the things that we did when I was in Pittsburgh, we did a support group tours of the grocery store. So we actually went to the grocery store together. And then we use certain apps. This can help. Once you know your profile, there's things like Shopwell and others, and you can scan a food product and determine how I can get a product without added sugar or without added sodium. So let's give our community the tools that empower them to make better choices. I think we also have to be careful not to shame and blame. Sometimes when we see people who are obese or eating that big gulp, we shame and blame. And the industry has a role to play here too. I'll just say this because I was on with a group of dentists last night, and they were telling the mom that their child had a tattoo on their tongue. You know, those drinks that make your tongue blue? Mm-hmm. Well, that tattoo had been there for like 3 days, meaning that kid was sucking on that blue sugary drink for several days. And the tattoo was not cute. The dentist had to say, that's not a good thing. So what is the role of dentistry? They see a lot of the consequences of the poor nutrition as they look into the mouth. And how can we have a multidisciplinary team? I think those are the ways that we can turn the corner.
And I just last week, I think it was, I was on a webinar with Feeding America, and someone gave the facts or anecdote that it takes somebody trying a new food about 12 times before their palate gets used to it and really starts liking that new taste. So I think do that community outreach, like you mentioned, cooking demonstrations and taste tests, the more we can get those new foods to the people where they already are, will only, I think, encourage that or help with that more healthy eating.
Because if you've never been exposed, you just don't know. And also, I was afraid. I'm going to be perfectly honest with you. I do all the cooking now in my house. But my wife would say, just follow the recipe. And for whatever reason, I'm a guy, okay? It just took me time to have confidence in so-called following recipes. But Adam, the problem is now that I'm good, now I'm doing all the cooking in the house. and now I understand, Simone, why I'm trying to overfeed people. I'm trying to overfeed them because when they eat my meal and they say, oh, this is so good, I get this warm feeling of love. So eat more. And so the other thing is portion size and helping people adjust portion size. But food is tied up with a lot of emotion. Mm-hmm. And I think that it's important that we recognize that. And therefore, it's about moderation. It's okay to eat grandmother's pound cake. Yeah, it has all that butter in it, but that's only once a year. You just don't do that every week. And you definitely don't eat the whole pound cake at one sitting. All right.
Simone, I wanted to go to you. Someone asked, what motivated UPMC to provide the kind of intervention you were talking about? Was it, patient demand, or did that come from some other source?
Different programs come from different motivation. So, for example, we have, of course, the clinical nutrition team reports up through me. So we have a lot of conversation about what is on a local level, on a national level, what's out there, what's in your community right now, what is really hot and heavily discussed, what can we implement. And so secondly, we are about to create at the hospital, in conjunction with, I believe, the University of Pittsburgh and various grants, a lifestyle medicine program. And so what that really does is focus on using food to help reverse lifestyle acquired diseases. And so we started several years ago, offering Whole Foods plant-based menu options. We still call sometimes Meatless Monday, even though that term is probably at this point fairly old and fairly worn out, but just to justify why one station in the entire cafeteria will have something plant-based. And just to Dr. Thomas's point, expose people to the new taste. And we would do little samples. We have a Wellness Wednesday once a month where there's a cooking demo. And prior to COVID, it will hopefully come back soon in the fall. And we would have recipes. But the key is it's either people within the department, it's either physicians who are very passionate about it. And something that I can share anecdotally that I don't have the exact data on is our Wolf Center, who looks at quality metrics and who looks at 7-day readmission and 30-day readmission, they found pre-COVID that the number one reason patients were readmitted in many cases was actually malnutrition and not what we anticipated was the not taking medication correctly. I think most of us thought, including myself, it's patients don't take their medication or don't take it correctly, and that's how they come back. It turned out in many, many cases that it was actually a malnutrition opportunity.
Well, yeah, I just, in doing some research for today's webinar, I came across a Harvard study that said 1 in 5 reasons for chronic disease across the world is a suboptimal diet, even more than tobacco or alcohol use. So I think, yeah, this idea of using food as a way to combat those chronic diseases, I think is really taking hold. Okay, so with the last 2 minutes, I just wanted to get this last question, especially Dr. Thomas, you mentioned the grant funding for these kinds of programs and sustainability in that. I'm wondering what role there is for public and private health insurers when it comes to prescribing or using food and nutrition as a way to combat chronic illness.
I think it makes a lot of sense in our own work. Our first major funder of the barbershop outreach was an insurance provider. It was Cigna, the Cigna Foundation. And there at UPMC, you're both a medical system and you're a payer. You have, I kind of forget the name, but you have an insurance company. And so, and I know the battles are probably still going on there with Highmark and all that, but that's good. Competition is good. This is a differentiator where you're incorporating food, nutrition, and education, and actually giving people the tools they need to prevent these cardiometabolic conditions that they're suffering from. So again, when I'm working with the insurance companies, Adam, it's on their foundation side. I'm trying to figure out how to get on the corporate side. And I think one of the ways to do that is for the barbers and stylists to have sufficient training to become certified community health workers. Once you're a certified community health worker, that hospital system recognizes you as a frontline healthcare worker. And then the key is not to destroy the trustworthiness that they have by forcing them to work in a hospital. No, you want them to work out in the community, but they're your partners in the community. They're your intelligence in the community. And when you're in there, Simone, and many of these black barbershops and beauty salons, people are walking in with food samples. It's usually wings, fried chicken, but it could just as easily be wings done healthily. Okay, there are ways that and so it's a nice place for consumer feedback. And again, I think this is a key. There are a lot of diagnostic tools that don't require you to be in a hospital or a clinic. And if we deploy these in those settings, I think it could be a win-win. For the health professional, it's an opportunity to practice their cultural competence skills. And for the community, it's an opportunity to demystify the medical jargon. To meet a gastroenterologist in a beauty salon is a lot better than meeting them in the emergency department, okay? So we want more. I met a health professional in my beauty salon barbershop. We want more of that and less of I met them for the first time in the emergency room. I think that the pandemic has given us an opening and we should embrace it and take it.
Fantastic. Thank you so much. Unfortunately, we're going to have to stop there. It's at 1:01 now. I want to thank both of you and Chairman Frankel for joining us today. Thank you, everyone, for attending. Again, we will send out the recording of this session in the coming days. It'll also be housed on Food 21's website. And please join us again in the future for our future sessions.